Hi, well, welcome everybody from Ohio. I know most of you are up in the Northeast and probably enjoying the cooler weather than what we've got here, but we're sending you some warmth, so fear not, it's still coming. The topic we're talking about tonight is a little bit on something you've probably seen in your travels more than once. These are one of those patients that you tend to see more often than not as a repeat customer as well, and that's your patient with COPD. So we're going to discuss a little bit tonight on both aspects as to what it is, kind of what happens, and then what can we do about it. And I've kind of put this up into kind of a storyline. So we're going to follow the adventures of two people that are separate yet somewhat similar in the way that their ailments actually start to affect their lifestyles. But when we look at COPD, it's one of those things. The key about this is the first word, it's chronic. So it's one of those things that when we get called, we're actually dealing with an acute exacerbation of something that's always going to be there pretty much in some way, regardless. And because of that, we're just managing them to make them feel a little bit better and hopefully reverse whatever acute issue is there. But we'll never really solve their underlying problem because, as you're going to see, anatomically and physiologically, the damage is already done. And that's why it becomes chronic, is because that can't really be reversed by any means whatsoever, at least not right now. That being said, if any of you out there down the road in your travels in medicine ever come up with a remedy and or a treatment for COPD that is permanent, it automatically reverses it, I want to be in on that, and I'd be glad to donate any kind of funds necessary because we'll be rich people for the rest of our lives, that's for sure. When we look at what it is, though, it's basically one of these two disease processes. Most people have just one, but there are a lot of people that have a combination of both. And it just depends on their lifestyle, their genetics, their environment, and a lot of other things. And we'll talk about some of those as we go along here. All right. So we're basing this tale, if you will, on a fictitious city that I made up called the city of Carcinoma. And it's not like any other city that you see. It's got its industrious side, it's got its hoity-toity rich side, it's got its yuppies, it's got its homelessness, and it's got everything else that you'd see in a major big city. However, in this city, it's uniquely divided in half by a set of railroad tracks. And on one side of the tracks is more of the, like I said, the industrious type of environment, whereas on the opposite side of the tracks, it's more of the upper class and the $1 million homes and so on and so forth. So we're going to kind of use that as our comparison and contrast as we go through that. So we're going to start on the south side of the tracks, and that's where Betty lives. And Betty is a retired school teacher and has had a very long life, but she unfortunately has been living on the south side of the tracks all of her life as well. She comes from a family that the house has been in that family for generations. And as a result, she's just kind of picked it up as other family members have passed on. When you look out her front window, this is what you see. There's a large refinery across the street, and there's again a lot of other industry that's in that area. So pollution, among other things, tends to be one of the more common ailments that exist in that particular area. So being that she's lived there all her life, unfortunately, she's been exposed to this, and that has led to her developing what we call chronic bronchitis. And with that, this is the textbook definition of it. And you can read it just as well as I can tell it to you. But the key is that by this definition, you have this person that is having some difficulty on many months out of the year for at least 2 consecutive years. Now, does this go on longer than this? Absolutely. And people get initially diagnosed with this definition, but they never really seem to get over it. They're managed. Some days are better than others. Some days are worse than others. And those are the days we typically would respond and maybe help them out. But how did they get there in the first place? Well, in her case, it was more environmental than anything else, being exposed to those pollutants, among other things, for a very long period of time. Now, as a result of that, this is what she's got going on the inside. And you see this a lot, no matter what the source was behind the bronchitis, that tends to be more of a COPD type of bronchitis. Your patient has very similar types of issues going on. This is why we see what we see. This is also what we're trying to kind of remedy, so to speak, when we're trying to help them out. The first thing is that they have this chronic inflammatory process. The irritation from the pollutants and whatever else that might be in the atmosphere has caused her, among other things, for her lower airways to be chronically inflamed. Now, in the bigger airways, that's not such a big deal. But when you get down into those medium to lower airways, there's not a whole lot of space there on a good day for all of us that don't have a problem. Add this onto those airways that are maybe on a good day a millimeter wide. Well, maybe now in her case, it's a quarter of a millimeter or half a millimeter, and that's on a good day for her. So what does that do? Well, among other things, first thing that it does, you can see in the pictures there with comparison with a normal and an airway with bronchitis, is that it increases that airflow resistance. It makes it harder to get air not only into the system, but also out of the respiratory system. That airflow resistance increases her work of breathing, which, among other things, can lead to her being chronically tired more often. And the other thing is that volume that's getting through there. So A, it's harder to get it down there, and B, just by that smaller lumen, there's just not a lot of volume to begin with anyways. So her oxygen content on a daily basis, even though she is having a decent day, that narrowed airway doesn't allow as much oxygen to get down there as what we have. And that can cause a big problem, as we're going to see here in just a minute. So the inflammation causes that airway issue like you see here, but the inflammation also leads to scarring. Scar tissue from the inflammation when it resolves itself, even though she may be on steroids and inhalers and all kinds of stuff like that, over time, this scarring tends to cause a bigger problem. And because of that, what happens is that you get a inflexibility, if you will, of these little hairs, which are called cilia. And they're located on the inside of these lumen. And what their job is basically to move mucus from the inside of the airways and trap mucus or trap particles, and then move that mucus north, basically to the upper airways, so that you can expel it and keep the airways clear of debris and so on and so forth. The problem with the scarring is that the normal pattern that you see where it moves in one direction, kind of like the wind socks that you see at the car dealerships and stuff like that, to have faces and stuff paint on them and they kind of flap in the wind. That's kind of what cilia do. And as they move that mucus in one direction, which is again north out of the airways. Given time, it doesn't do that anymore. Or if it does do it, it doesn't do it very efficiently. So what that leads to is the mucus is still there, but now that mucus stays in those lower airways longer, and whatever's trapped in that mucus also stays in those airways longer, which leads to, among other things, pathogens staying in those lower airways longer than they should. That adds into more inflammation. More inflammation then leads to more narrowing of those airways on a more permanent basis, which leads to more damage to the cilia, and it becomes more of now a kind of a snowball effect, where now just one thing just kind of precipitates another and just gets worse and worse and worse. Now, the problem with the mucus is twofold. One is that, well, we just can't move it, as you see here, because of that loss of the cilia movement. The other problem is that because of this irritation of the pollutants and whatever else is causing that lower airway irritation from what they've inhaled, that also causes the natural mucus cells to overproduce more mucus. And by doing so, and staying in those lower airways longer, it tends to thicken up more so than what it normally is. So now I've got basically mud that I'm trying to move through small airways that are overinflamed, and the mechanism that's supposed to move it doesn't move it very well to begin with. Now it doesn't move it at all. And things start to become more and more condensed and coalesced in those lower airways, and the airways become smaller in diameter as a result, because now I've got not only swelling, now I've got mucus that I can't get rid of. It's thick. I've got that chronic congestion now that you always hear when you listen to these people's lung sounds. They just sound like garbage in there because you hear all this rattling going on. Well, that's that mucus that's trapped in there that they can't get rid of for the reasons we just talked about. All of this leads to again, another addition into that ability or inability for that patient to be able to ventilate effectively. Not only getting air in, but also getting air out. And as you saw in the picture, that small amount of air that did get through is just that. It's a very small volume. It's not an adequate volume. And now that volume becomes less and less the longer and longer this process goes on. And Betty is, pretty far into her age at this point. So she's got a lot of issues going on in those lower airways. She started off in her younger years like this, nice and clear, no inflammation, air moves in and out, life is good, we're getting oxygen in, we're getting CO2 out, yahoo. But now, over time, with the inflammation, with the mucus buildup, with the lack of the cilia being able to work because of the scarring, and all that narrowing of those airways, now we're dealing with a situation like this. So you can see just by comparison how much smaller the space is for air to move. On top of that, it doesn't move very smoothly because now it's traveling over all this mucus and bumpy road. And on top of that, it's also swollen up, so those airways don't expand very well to allow good airflow to get through. All of this has a consequence, right? This is one of them right here. Now, obviously, since we're looking at this is not in a real patient, but what you're looking at here is the main airways. Let me see if I can use this to show you. We're going to draw here. So what you're seeing right here is the trachea of this particular patient's anatomy. Down here would be the right bronchus, right main stem. This would be the left. Okay? Heart's sitting somewhere down here. But you can also see throughout all this how all that yellow or whitish type of sheen to the inside, well, that shouldn't be there. Right? That's all mucus. And when we listen to patients' upper airways that have bronchitis, especially, you hear that rattling, that rhonchi that they always describe. Well, that's why, because all this mucus that's built up over time from this bronchitis type of process, that's sitting there right now, and that's what it looks like. So that's what's kind of going on with Betty, not only in the upper, but also those lower airways. And as I said, in the upper airways, it's not such a big deal because there's still enough space for air to move because they're bigger airways. The problem is that when it gets in those lower, smaller airways that are normally small to begin with, now you've made them much, much smaller. And the big issue is if air can't get from point A to point B, i.e. your upper airway all the way down to the alveoli and back, then you got an airway obstruction. So literally, Betty is walking around chronically with a mild to moderate airway obstruction on her good days. And then when we get called, usually it becomes more severe. All right. Now, what the mucus also does by sitting there is that not only does it take up space, and it also decreases the inelasticity, it turns those airways basically into concrete. And so they will be able to expand a little bit when the patient breathes, and that's only because when she breathes, she's got positive pressure. She's forcefully moving air into her system. The problem is that exhalation is always a passive process. And as a result of that little bit of expansion that she gets, the airways, because of the condition that we've just talked about, naturally just collapse. And that mucus obviously adds on top of that she's built up. And so what happens is she starts to do what we call air trapping. Eventually, what's going to happen is she's going to have a mismatch of her oxygen and carbon dioxide content because of that. Now, you saw the narrowing of those airways. She is getting oxygen. However, the amount of oxygen that she's getting and the pressure that it's under is much, much less than your average patient because there's just not enough space to move the air. You have those inelastic types of airways, which now don't allow for that volume to get through either. And so whatever air reaches the alveoli, well, the alveoli are still intact, and that's what she's got going for her. The problem is that the amount of air that gets down there, the volume and the concentration of oxygen within it is chronically always very, very low as this disease process goes on. So as a result of her condition, she's always going to be hypoxemic, which is low oxygen in the blood. And because there's low oxygen in the blood, well, now her body's cells also become hypoxic because they're just not getting fed like they should. Now, on the reverse side, her body's always working a lot harder because of that lack of oxygen. So she's as a result, producing a lot more carbon dioxide than say we do. She's running basically like a marathon every day, producing as much carbon dioxide as a marathon runner would. Only she can't get rid of it. It will come back to the lungs, it'll circulate, but once it gets in the alveoli, those alveoli don't have enough pressure to push past the obstructions that are above it, the airways that are collapsed, that are narrowed, and the volume, again, on that passive type of return, just doesn't have the punch that she has when she's actually inhaling with that active process. So she's in a scenario now like this. So as you see on the picture on the left, she'll breathe air in, very, very little air gets down to the alveoli, as I said, very little oxygen as a result. When she goes to exhale, well, those airways collapse, the mucus collapses, the amount of volume that's coming in is much more than the volume going out. And so proportionally, you get very little CO2 removal. There's some, but all of it's not gone. So what starts to happen is that as that air starts to trap, as you can see here, and it starts to expand those alveoli, what it will do is eventually is that carbon dioxide is going to build up enough in that alveoli that it's just going to fill it up, so to speak. Now the carbon dioxide that's coming back from the body, right, the amount that's in the bloodstream versus what's in the alveoli, there's too much in the alveoli compared to what's in the bloodstream. So now carbon dioxide won't leave the bloodstream. It will actually just keep right on going because the diffusion gradient that's supposed to be there, low oxygen or low CO2 in the alveoli, high CO2 in the bloodstream, there's a mismatch now. So CO2 can't move towards the alveoli. It actually stays in the bloodstream and it just moves right on by. Carbon dioxide starts to build up in the bloodstream, and that's when your patient becomes acidotic. And that in and of itself causes a myriad of problems with their acid-base imbalance. So she's got that going on as well. So that's something else we have to deal with when we see these patients.
Wow. That means you had a good practice.
Yeah. Notoriously, what happens though is we get these patients that we give them this misnomer and nickname, we call them blue bloaters. Well, the blue part comes from the cyanosis, the lack of oxygen that doesn't get down to the alveoli, that doesn't get in the bloodstream, that doesn't circulate. So eventually that hypoxemia starts to manifest as that gray, dusky, kind of bluish, icky kind of color that you see with a lot of these patients that have either an exacerbation of their problem or sometimes chronically just look that way. But what's the whole thing about the bloat? Well, the first problem is that if there's hardly any oxygen in the bloodstream, your biggest expenditure or user, I should say, of oxygen is the brain. And so it's going to take as much oxygen as it can out of the bloodstream. The problem is that the volume just isn't there. And so it takes up whatever it can, but even with that amount that it takes up, it's still not enough to meet the brain's natural physiological everyday needs. So the patient's always tired. Patient's always kind of feeling run down. Patient doesn't feel like getting up, doesn't feel like doing anything, just sits around because they're just tired, right? And what happens? Well, if they're tired and they're sitting around, well, among other things, they're not really moving blood around like they should. They're also having a tendency to just gain weight, right? Because the body just metabolizes differently, and now fat's being used for energy because oxygen's just not there. So they start to gain weight, they start to eat, they start to watch TV, they get winded when they get up anyways, so they don't do it very often, even if they do. And so they're sitting around more often. And again, this becomes more of that snowball effect. Here's another consequence that leads to that hypoxic problem. Because of the fact that they're building up carbon dioxide, okay, the brain has to figure out a way to buffer out all that carbon dioxide. And it knows that there's carbon dioxide building up because that acid is building up because of the high concentration of carbon dioxide. So what the brain does, it tells the bone marrow to build more red cells. Figures if it has more red cells, it can pick up more carbon dioxide, it can take it to the lungs, we can get rid of it. Brain has no idea of what's going on in the lungs at this point. It just knows that it's not getting enough oxygen, there's too much carbon dioxide, and I got to fix it. And this is the best way to do it. So here's the issue. You build up all these extra red cells, but now because of this proliferation of red cells, there's more red cells than what there is plasma volume in the bloodstream. And now the blood starts to get very, very viscous as a result. It still flows, but it flows much slower than what it used to. Right? And that starts to put strain on the heart. Strain on the heart is already there because it's not getting oxygen either. Now it's being forced to pump this thicker blood with less oxygen and less ability to do so because the muscles just aren't being fed. So that complicates things. And eventually what that's going to do is that it's going to start to build up pressure within the bloodstream itself. In the lungs, as that thick blood just isn't moved through very well, eventually that pressure is going to start to be put on the right side of the heart, trying to force this thick blood through the lungs. Now, it can do it for a while, but eventually it will start to give and it will start to overgrow the right side because just like anything else, the right-sided muscle is being overtaxed because it's trying to push against resistance, okay, trying to push thick blood through capillaries in the lungs. And the right side versus the left, well, the right side doesn't have a whole lot of muscle to do that in the first place. So the problem is that once this muscle on the right side starts to overgrow because of that buildup of pressure in the lungs from that thick blood trying to move it forward, this is the consequence. And what you see here now is a couple of things. One is that, well, yeah, that muscle gets bigger, which is a good thing. The problem is that in this case, that muscle is very inefficient. It doesn't contract nearly as well as what it does than that picture on the left. The second problem is now, as you can see, the filling space, because of that overgrowth of the muscle, well, it doesn't grow out, it grows in. And so now there's lesser volume being moved through the lungs. It's harder to move it through in the first place. So what does this do? This slows down the process of the blood flow even more so through the lungs than what it was. And so now you have this patient developing a condition what we call cor pulmonale, which is basically right-sided heart failure secondary to pulmonary hypertension. You know, pulmonary hypertension is that thick blood producing that harder means of trying to move it through the lungs through the pulmonary capillaries, right? So now we got that problem. Eventually what's going to happen is that that blood is not going to be able to fill that space very well on the right side. So now that pressure is going to not only back up into the right heart, it's also going to back up into the right side of the systemic circulation, which is the venous system. And we're going to see consequences of that. So if we're not moving a lot of blood through the lungs because we can't now, well, again, we're not moving it very well throughout the system. The heart's hypoxic just as well. It doesn't pump very well anyways, even on the left side. So now circulation to the extremities becomes affected as well. The cyanosis becomes more and more evident, or the grayness, or that icky kind of, pale kind of color that these patients have a lot of times. That lack of circulation to the extremities, among other things, can lead to ulcerations, cellulitis, especially in the lower extremities because of gravity. That's where it's going to happen first. And so now you could have that chronic bronchitis patient that's also septic because of the wound that won't heal. And now you've got another problem on top of a problem that was already a problem on top of another problem. It just becomes a big, big issue, right? All right. But they also develop sometimes ascites. This ascites, what this is from, is actually fluid that's backed up on the venous system. Remember, that right side is failed. And so the fluid backs up into the superior inferior vena cava. And when the fluid backs up into the inferior vena cava, eventually a branch off of that leads through the liver. Once it passes through the liver, it leads into the intestinal circulation. And now the pressure builds up too high in the intestinal circulation and those capillaries, and the fluid just leaks out. And over time, they develop these big water bellies that you see here, which can be problematic in another way. If they're sitting down all the time, which they are because they're tired. Now, all of a sudden, you've got this big, large basketball that's sitting in their belly. And what's it doing? Well, now it's pressing up against their diaphragm, and that impairs their ventilation even more. And that just exacerbates the problem even further. And so again, one thing just starts to make another thing bad, and it just gets worse and worse over time. And especially since this is a chronic condition, they never get better, they always get worse. And this is one more consequence of it. Another thing you may see on their assessment, especially when you look at Betty's, you might see JVD while she's sitting up. Because remember, the pressure goes both ways. It goes down, and typically you're going to see those consequences first because of gravity. But you're also now going to see this chronic JVD as she's sitting up because the pressure is building up in the superior vena cava. The brain's trying to drain past an obstruction, which is that high pressure on the right side that exists now because of the failure of the lungs being able to oxygenate and the capillaries producing, again, too much resistance with that thick blood on the right side of the heart that fails. So needless to say, she's a mess. And one last thing that you might see on any COPD, not all of them, but occasionally you do, is because of this high carbon dioxide concentration I mentioned as well. They can't get rid of it. It's circulating and now eventually starts to back up in the blood, and those levels start to go higher and higher. And that's, again, going back to the brain trying to get rid of it. But that level of CO2 eventually in the extremities, like the hands, for example, high concentrations of carbon dioxide in the bloodstream causes your blood vessels to dilate. And in this case, in the outer extremities, when those capillaries dilate, now they leak a little bit easier. And what you're seeing here is a manifestation of that is fluid. And this is what you've probably heard the term clubbing of the fingers. That's what that is. And I've actually only seen this once in a patient who had COPD, and it was pretty impressive. But the vast majority, and you may agree with me, that the vast majority of the COPDers I've ever taken care of, I don't really see this. So if you don't see it, it's not really all that uncommon. If you do see it, though, pretty much only one thing that's causing it, and this is probably it. And you've probably figured it out by now that your patient has some form of COPD that we're trying to manage. And that's why we were called there in the first place. So needless to say, Betty, as I said, is kind of a mess. And she's been homebound for quite a number of years. Obviously, the environment she's living in is just exacerbating her condition. She can't get up. She can't move around. She's constantly tired. She's, very hypoxic for the most part. Her lower airways are a mess. Her alveoli are intact, so she got that going for her. But that's about the only thing that's really structurally intact. Everything else in the body is kind of falling apart. Right side of her heart starting to fail. Obviously, you see problems with fluid distribution, poor circulation to the extremities, hypoxic cells. I mean, it's a pretty bad deal. And it's something she really didn't deserve, but unfortunately, that's the card she was dealt. So we're going to leave her story for just a minute. We're going to go to the other side of the tracks. I want you to meet Earl. Now, he lives on the good side of town, so to speak. He comes from money. He's always had money. He's never had to want ever in his life. He went to Harvard. He got a very large business that was given to him, and he ran it for a number of years, and he retired a very rich man, and he lives now on the north side of Carcinoma, on the other side of the tracks. But he has a vice just like a lot of us do, and his happens to be smoking. And sometimes he smokes a little, sometimes he smokes a lot. It goes from day to day. It just depends what his mood is, where he's at, if he's at a party, out with friends, whatever the case may be. But he's able to get out. He's mobile. He's still a social person, still likes the ladies. The ladies still like him. And so occasionally he may smoke more days than others just because of his circumstance. But as a consequence of that, as there are for everything, he's developed what we call emphysema. And this, again, is your textbook definition that you see here. He has a lot of similar problems that Betty does, but he has a lot of different problems as well. And we're going to compare and contrast those here in just a little bit. But I'm going to explain to you kind of what emphysema does. As you can see, it's an enlargement of the alveoli that's abnormal. And as a result of that, it's coming from actual destruction of lung tissue. So his problem is simply because of the fact that he is a chronic smoker for, at least in this case, 50 to 60 years, if not longer, the exposure to nicotine, among other things. Not so much the smoke, but the nicotine that was in the smoke. It does a lot of damage internally that cigarette smoking in and of itself, obviously since it's inhaled, also causes lower airway issues, a little bit of inflammation, irritation, and so on. But the nicotine content is the bigger culprit. Not to get into a whole bunch of chemistry here because there's a lot more to it than I can probably explain, but bare tax, what it comes down to is that when a certain level of nicotine is attained and maintained throughout the bloodstream and also within the tissues of the various body organs, it activates this enzyme, which is called elastase. Right? And normally what it's there for is to keep the elasticity of our airways, which is nice. When it's overactivated, though, it's kind of like that old adage, it's too much of a good thing. And it does just the opposite. It actually destroys and inhibits the elasticity of the airways. Structurally, they're intact, but their ability to flex is lost over time. And that's what's now happening with Earl. So just to give you some comparison here, this is what a normal lung looks like. Obviously, if it's inside someone's body, more likely it would be much better. And you look at this, and a lot of people say, well, it's not normal because there's all those black streaks on there. I mean, for crying out loud, that's not normal. That's bad. Well, it is and it isn't. If you never smoked in your life, if you live in some type of a very sheltered bubble type of existence, yes, your lungs will not look like this when you die. However, most of us have had some urban experience of some sort. We're around car exhaust, we're around industry to a degree, whatever the case may be. This is just normal everyday living. Okay, this came out of a 90-year-old patient who died from CHF. And those black streaks are just a result of 90 years of just living her life, right? Just pollutants that eventually have picked up. But if you look closer at her lung tissue, right, you can see that it still has a very spongy, very good consistency to the tissue itself. That's what lung tissue should look like, what you see there in that cross section. What happens with emphysema is, like I said, that loss of elasticity not only damages the airways, but in the case of Earl, it also damages his alveoli. And so they lose that elasticity, they lose that ability to basically constrict and force air up on exhalation. Now, what will happen even more so over time is that these individual alveoli will start to basically just erode away altogether. And those walls now, instead of having individual small air pockets, now become very large air pockets. And the ability to perform respiration is also decreased, not to mention the fact of being able to exhale is greatly compromised in your patients that have emphysema. And it's because of this loss of elasticity that you see here. They can get air in, right? They got no problem whatsoever because when they're taking a breath in with that positive pressure, they don't have the problems that Betty did with the narrowing and all that other stuff. His airways, for the most part, are okay. So they expand, air comes down, the volume gets down there, and any alveoli that's still near a blood vessel, it's going to exchange carbon dioxide and oxygen pretty well. The problem is that what you see here on the right side is that the vast majority now of Earl's airways are doing that, right? The air comes down, but when he goes to exhale, the airways above the alveoli collapse, the air gets trapped. And so even though a good concentration of oxygen got down to there and can still get in the bloodstream, the carbon dioxide problem that Betty has is the same thing that Earl has. He can't get rid of it in a normal fashion, in a normal volume. And so over time, he starts to not only trap air, as you see, but he also starts to retain carbon dioxide, and that becomes a problem for him as well. Now, another problem with that elasticity loss and obviously damage to not only the airways, but also the lung tissue itself. You start to eventually get lung tissue erosion. And what will happen is that air can now travel freely out of those airways and actually out of the lung if it wanted to. The good thing is that we have a covering over our lungs called the pleura. And in this case, what you're seeing here is the visceral layer of that pleura. The parietal layer is what lines the inside of our rib cage, and the two stuck together is what allows the lungs to expand and contract, which allows us to ventilate. This, what you're seeing here, is a air pocket of visceral pleura, and it has a name which is called a bleb, okay? B-L-E-B. Now, sometimes they don't get this big. Sometimes they're much smaller than this, but sometimes there's many more of them. And there are little air bubbles, which are basically on the outside of the lung, okay? Because air is now moving from the lung tissue. It expands up against this layer. The layer remains intact and expands like a bubble, but fortunately, it stays intact. If that were to pop, now you've got free air that's going into the thoracic cage, and your patient develops a pneumothorax. So Earl has that predisposition, and he may have a number of these in his airways, or in his lungs, I should say, but none of them have ruptured yet. Sometimes they get very, very large. And in this case, you've got a couple on this specimen here that were quite significant. That can take up space, among other things as well. All right. So as I said, as those alveoli start to become eroded, and those walls that now were individually, making little air pockets, now they become bigger air pockets. And the problem is that decreases in that part of the lung the ability for oxygen and carbon dioxide to exchange itself. It reduces that capacity. What it also does is that because now you've got these huge air pockets, is just that. It keeps that portion of the lung constantly inflated. And so what will happen is that over time, when more and more of this starts to occur, you're going to get these big air pockets over multiple areas of the lungs. And those lungs are not going to fully collapse when that patient exhales. So they're going to stay what we call hyperinflated. The lungs stay bigger, and as they get bigger and they can't collapse, eventually that process is going to be interrupted for us being able to ventilate. And how is that? Well, it's because what those lungs do now, if they're much bigger than normal, is that they're going to press down on the diaphragm, and it's going to make it much harder for that patient to ventilate. When that occurs, at a certain point, now that patient has to find a way to make up the difference. And if the diaphragm is compromised because of these hyperinflated lungs, well, two things are going to happen. One is that your patient is going to breathe a little bit more forcefully, but what they're also going to do is they're going to recruit different muscles to help them ventilate and also exhale. And that's even more so, is that they're going to put more effort into exhalation. And those are the accessory muscles that you see as far as the intercostals, the neck muscles, and so on and so forth. Okay, now remember, he's getting oxygen. His heart's got enough oxygen. His brain's got enough oxygen. A lot of his normal organs have the oxygen. So he can keep doing this, and he can put the effort in because he's got the oxygen to run all those mechanisms, unlike Betty that doesn't. So he goes from a scenario like this, which again, you had those nice individual air pockets, all having their own capillaries, and blood comes in and carbon dioxide goes in the alveoli, and oxygen comes in the bloodstream and goes back to the left side of the heart and goes to the body, and everybody's happy. So this is what we're at. Where he's at is a much different scenario. So looking at normal lung tissue again, you can see how everything's kind of compact. The airways are all where they're supposed to be. Capillaries move in and out, and so on and so forth. So the lung tissue is very elastic, and things move back and forth just like a bellows. When you have that breakdown, these are the pockets that start to develop. And they can happen anywhere, but eventually it becomes kind of like a contagious disease. Once one area starts to break down, then the area next to it starts to break down, and so on and so forth. So you go from those nice individual pockets you see down there in the bottom picture, you start getting those big air pockets up on top. And now that lung tissue starts to look like this. Once you start to have this, that's where all that air is being trapped in. It just sits there, right? And it keeps that portion of the lung always inflated, which again, eventually compressed under the diaphragm. It can also restrict the rest of the lung's ability to expand and contract normally. But because it's also now keeping that lung overinflated, it also keeps the size of that lung much bigger. But now it's going to require that patient to use other muscles to try and help combat this obstruction, which is really what it comes down to. This is also the air that's trapped in here that eventually, as the lung tissue itself above it starts to erode, that air is going to leak into that visceral layer and starts to bubble out and make those blebs that I showed you earlier. All right. Now, we call the emphysemics pink puffers. Why do we do that? Well, they're pink for a couple of reasons. One is the fact that, as I said, they're getting oxygen in. They're getting into their bloodstream. They're circulating it. And as I also mentioned earlier, carbon dioxide dilates blood vessels. So now I've got oxygen rich, very large amount of oxygen rich blood moving through dilated capillaries, and that's dilated everywhere, even to the skin. So it brings that very reddish tint to the skin from that proximal exposure of this very well chalked oxygen blood. Okay. Now, why are they puffing? Because, as I mentioned, they're using accessory muscles, they're using everything not to get the air in so much, it's to get the air out. Right? Because those airways, when they collapse and that air traps, right? Remember, oxygen getting in, they can't get the CO2 out because of that loss of the alveoli being able to snap back, and those airways above them with their elasticity that's been lost, they collapse just as well. So now we've got that problem again, similar to what air trapping happened with Betty, just a different mechanism. So this is your typical emphysemic presentation right here. Right? They're sitting forward. They're usually skinny as a rail. Why? Well, again, they've got oxygen. Their metabolism is going haywire because they're constantly trying to ventilate, trying to get the air out, but they're using up all their energy to do that. So they eat like a horse, but they burn up all that all that glucose. They tap into their fat stores, and they don't have anything left. Right? So they're constantly very, very thin in most cases because their energy expenditure is very high. They can maintain it because they get the oxygen in their bloodstream, but since it's always high, they're using more than what they should to breathe out. They need that extra oxygen, so the fat stores are just not there because fat's basically an energy reserve. If you're in constant need of it, you don't need to reserve it, you need to use it. And so we see this. The other thing is that they're typically leaning forward, and we'll talk about that in just a second, but they're also a lot of times pursing their lips. And that's their way of trying to forcefully exhale. Okay? It's their own way of trying to peep their airways, trying to expand those lower airways to try to get the air out. It's creating a back pressure when they purse their lips like this to open those lower airways. So hopefully that air can come out. And sometimes it's effective and sometimes it's not. Because again, especially this time of year, or especially with the last couple of years, with people that had COVID and get an emphysemic like this, and those airways get affected with that disease process, that can interfere with their normal ability to ventilate. They're already having a hard time. That makes it 10 times worse. So they also develop this musculature because, again, they're trying to work to breathe. So their neck muscles, for example, which help pull up on the upper part of the chest, pull up on the clavicles, and so on and so forth. Their traps, their scalenes, their sternocleidomastoids, all those neck muscles, they get huge, just like Schwarzenegger. But is it because they're working out? Well, yeah. I mean, they're not doing it in the gym. They're doing it every day, trying to keep themselves alive, trying to move air in and out of their respiratory tract. Right? The other thing that you'll see is that their intercostal muscles are also internal and external intercostal muscles also get larger because they're using those also to help them move those hyperinflated lungs in and out to breathe 24/7, 365. On top of the fact that if you look on that picture on the right side, remember I talked about all that air trapping in the lungs and keeps them bigger. Not only do I have lungs that won't deflate, so that makes the chest a little bit bigger, but now I've got those hypertrophied muscles in the chest. That increases what we call this anterior posterior diameter. Okay, the front and back becomes much wider than your normal patient. And a consequence of this is what you see here. So now Earl, most of the time when he's sitting, kind of looks like he's always just kind of hunchbacked. Well, he's not really necessarily doing that on purpose. He's doing that because that's the way he's able to only sit because of those hypertrophied lungs, because of that increased area of diameter of the intercostals creating the extra musculature in the chest. That barrel chest that you always hear about in emphysemic patients, that's why they develop it. The bigger lungs and the bigger muscles within the chest. But there's a consequence of that. Like I said, this is what causes a problem. Now, as you see while he's sitting here, what is that doing? Well, it's also putting pressure on the diaphragm. So it makes it a little bit harder for him to ventilate. Thus, the fact that, again, the passive amount of air that he's trying to get out is a lot less than what we normally have. So what does he do? He uses those pursed lips to try to force the air out. But even by doing so, a lot of times the amount of carbon dioxide he's trying to exhale still is not enough in proportion to what he's bringing back into the lungs. So it backs up in the bloodstream, just like it did with Betty. And he has those same problems with acid buildup and so on and so forth. He also now has a problem with that right-sided heart failure. A little bit because of the fact that now you've got lungs basically that are overinflated, pressing down on the heart, which doesn't help. But now with all these individual air pockets like you see here, they're pressing down on the capillaries that feed the lungs in the first place. By putting pressure on those lungs, it squeezes them down. And just like thick blood causes a pressure buildup in the lungs that back pressures and causes the right side of the heart to work too hard, here, those constricted, if you will, blood vessels in the lungs, those pulmonary capillaries, does the same thing. And eventually the right side can't overcome that pressure. It builds up that extra muscle like you saw in the previous picture. Okay, it starts to fail. Okay, the volume that's filling becomes less and less. And now that patient also develops what we call cor pulmonale in some cases. All right. So Earl's not as much of a mess as Betty, but he ain't much better. All right. So let's kind of look at both of them here and see, just as a summary, what's going on with these guys. Because when you deal with either an emphysemic or bronchitis patient, a COPD, or like I say, sometimes they get a little bit of both. If they're one versus the other, well, here's what you've got walking in on a good day for these patients. Go back to Betty. Again, she has the fluid buildup because of the right-sided heart failure. She's overweight because, again, the low oxygen content. She doesn't get up. She doesn't move around. She gets easily winded. So she just sits around just kind of like a bump on a log. She does have a cough because she's always producing mucus that she can't get rid of, as we've talked about. But is it productive? Yeah, in those upper airways, it very well could be, because those airways don't collapse. The problem is that they're so narrow, you don't get a lot of air pressure behind it. So what she does bring out usually is not enough to clear what's in those lower airways. Because remember, we've lost that ability for those cilia to move. The mucus has gotten much thicker. And she's constantly sick because she's trapping whatever's in that mucus in those lower airways. She's not expelling it. And so that inflammatory process just continues. Her cyanotic complexion, because of the low oxygen content that's circulating through her blood. Now, her blood vessels are also dilated because she's got a lot of carbon dioxide. But that blood has very low oxygen content in it. So when it goes to the skin and you see that, it has that bluish tint to it versus the reddish tint that you would see with Earl with his dilated capillaries because of the retained carbon dioxide. She has resistance going both ways. Obviously, getting air in past those very small airways, and obviously much smaller airways as she's trying to get it out. As I said also, she's got that advantage. She does have those alveoli that are intact, but that little bit of push that they can supply is minuscule compared to the pressure that's above it, and it just can't bypass it. Now, we look at Earl. He has that very thin, barrel-chested type of appearance. Remember, he's burning up everything he brings in. Glucose, fat, doesn't reserve anything, uses it up as he's going along, so on and so forth. He also has those hyperinflated lungs. So not only does that keep his chest expanded, but it also causes him to hunch a little bit, puts pressure on the diaphragm, makes him have a little trouble breathing. But you've also got the hypertrophy now of the neck muscles, of the chest muscles, and that increases that size of the chest as well, shooting that barrel chest as a result. If he has a cough, a lot of times it's non-productive because that inelasticity of those airways, when they collapse, they don't allow things to get out. The pink complexion is because he is getting air down. Okay? He's circulating volume very well because he's fully oxygenating for the most part in most cases to a normal degree. So everything's working the way that it should, and he's circulating very oxygenated, rich blood to the surface of the skin. The pursed lip breathing, trying to overcome that elasticity, the collapse of those airways. So he's trying to purse his lips, trying to create back pressure in those lower airways, trying to open them up, kind of like what we do with PEEP, with CPAP and things like that, trying to move the air out, which he does not very well over a period of time. His alveoli are toast. His lungs are toast. His airways, for the most part, in those lower portions are just losing all kinds of integrity. So now you build up those big, big air pockets in the lungs like you saw. And again, as a result of that, he can't move his chest very well. Unlike Betty that has some elasticity, he has none as far as chest excursion goes. All right. So let me let you in on a little something here, because I only told you half the story. So we go back to high school, and Betty, they both went to the same high school, Earl and Betty did. Earl, or just to say Betty, was captain of the cheerleading team. Earl was the star quarterback. And back in high school, they kind of had a thing and kind of had the hots for one another and actually dated for a little bit for their junior and senior year. The problem was is that Betty was from one side of the tracks and Earl was from the other, and their destiny was predisposed to go in opposite directions. And unfortunately for them, that's exactly what happened. And so when you see a COPD or a bronchitis patient or an emphysemic patient solely by themselves, they're kind of an entity upon themselves. And that's what kind of happened with Betty and Earl for a long time, over a period of years. All right. As I mentioned, Earl had money. Earl went to Harvard, had a business degree, had a lawyer degree as well, became a lawyer as well. I forgot to mention that. Was very well off, has money, kept his money, still has money to this day. Betty didn't do as poorly as most of the people from her side of town. She was able to go to college. She was able to get an education degree, and she was a local high school teacher until she retired, and then again has been living on the south side of Carcinoma for the remainder of a few years up to this point where we now have met her. So at that juncture where the tracks were, there are suburbs that exist in there, and there's a grocery store. And it just so happens on this day that Betty and Earl, unbeknownst to each other, have now gone to the same grocery store. Earl just happens to be going that way because he's heading out of town. Betty goes there all the time because it's the closest place to where she lives. So they're going to meet up. And so what we're going to do now is by this junction of bronchitis and emphysema, we talked about the differences. Well, let's talk about some of the similarities. So Betty comes in on her scooter, her oxygen supply that's always on 2 liters, right? Earl comes in carrying his, maybe not so much on a trolley like this, but maybe he's got the portable device, the backpack or the side satchel or whatever it is that you'll see people carrying, but he's also on 2 liters. And they're both in the store at this point. They come down the produce aisle. He comes down on one end, she's down on the under. They're kind of picking through things. Eventually they bump into one another. And now Betty sees Earl and, well, they both get a little excited. Oh my God, I haven't seen you in 30, 40 years. And all those feelings that they had back in high school now just come rushing forward. And they both get overexcited to the point where, well, now it's a little bit too much for them. And now they both have difficulty breathing. And we are called to the grocery store for not only one, but now 2 patients that are suffering from an acute exacerbation of their COPD. So off we go. And now we're going to be taking care of both patients. They both tell us they've got COPD. So we know that there's some differences between the 2 of them, but what are some of the similarities? And as I've talked about with both of them have issues with their lower airways that are now much smaller than normal, either due to swelling, inelasticity, maybe a little bit of both. They both trap air, so they both obviously retain carbon dioxide. They both suffer from pulmonary hypertension. One, because Betty's blood flow is so much thicker, and it just makes it harder for the blood to move through the capillaries, and that puts resistance on the right side of the heart. Earl, because of those air pockets that now have basically compressed the pulmonary capillaries, and makes it much harder for the right side of the heart to push past that. And again, that resistance in the lungs, that's what we call pulmonary hypertension. Both of them may have some degree of right-sided heart failure and or right ventricular hypertrophy, but it may vary a little bit, but it's probably there to some degree. All right. So with this, both of their problems lead to another issue, which we talk about, which is called hypoxic drive. Right? Hypoxic drive is one of those things where the body eventually gets used to the fact that, among other things, the carbon dioxide level is much higher than normal compared to the oxygen level. And what can happen, and what always is the fear of most providers, is that, oh my God, if we give them too much oxygen, it's going to reverse that. And the brain's going to be like, well, the brain's used to having low oxygen and high carbon dioxide because of this chronic condition. Now, all of a sudden, if the brain gets too much oxygen, the fear is, well, the brain doesn't want the oxygen. So it's going to cause the patient to stop breathing to lessen the oxygen intake. Does that happen? Yes. Will it happen in the pre-hospital setting? More than likely, not. Now, with all of you that live up in the Northeast, and again, you've got 3 miles to go, but it takes you like 3 days to traverse it through the mountains and stuff. If you're with the patient over an extended period of time, and we're talking hours, maybe, right? But even then, it's not a possibility for the most part. If your patient stops breathing, even though you give that COPD or oxygen, they were going to stop anyways. All right. Don't worry about it. We're going to manage them as we would anybody else that has respiratory failure or respiratory arrest. You're still going to ventilate them. They're still human beings. They still need oxygen. So don't worry about that. If they need it, give it to them. But on top of that, what else are we going to do for these patients? The first thing is that not only giving them the oxygen to relieve that hypoxia, but we've got to find a way to open up those airways so we can get the oxygen down there and or get the CO2 out. And so that's going to be the second part of what we're going to do for these people that are having this chronic exacerbation of this problem that they've got regardless. So with the airway, obviously, what do we want to do? Make sure it's patent. If they're coughing up all this nasty stuff, let them keep coughing as long as they can. They're clearing their own airway. If they need help with suctioning, so be it. If you need to position them on their side, so be it. Take a look and see if there's anything that you can do to help them just kind of facilitate that. Some of them need help just sitting up so they can use those muscles and they can use that diaphragm. As far as the breathing goes, make your assessment. It's a case-by-case basis. In this case here, both Betty and Earl are kind of hyperventilating and having difficulty breathing, and coughing and hacking, and it's a big mess because of this, sudden meeting that they didn't expect. So one of them may need more oxygen than the other. So give them whatever they need. We're trying to maintain a decent pulse ox. Some of them, you're not going to get it very high just because of their condition. We like to aim for, 90-ish, if not better. But if you're not able to get it that high, or if it only climbs a couple of points, so be it. But if it remains in the 50s, 60s, or 70s, they probably need to step up the way that you're administering the oxygen, and maybe it comes down to ventilating, and in an extreme case, maybe intubation in the advanced provider's realm. Circulation-wise, again, more at the advanced level. Obviously, we want to try to get the IV started. Fluids are going to help in this case, as long as they're not overhydrated anyways, and they're not retaining fluid. It'll help to thin out the mix a little bit. It also is going to be a route for medications if we need it. But a lot of these patients, because of their condition, they're constantly having a respiratory rate that's much higher than normal. And so they naturally get dehydrated. You look at Betty and Earl, just being elderly like they are, they're already predisposed to being dehydrated anyways. Add on the fact they've got COPD, now they're probably super dehydrated and super dry. A little bit of fluid will probably go a long way with some of these patients. When you get them on the monitor, don't be surprised if you see some kind of funky rhythms, either due to the hypoxia, either due to the chronic strain on the right side, which a lot of them go into atrial fibrillation. That's okay. As long as it's not a rate issue that's causing the problem, we're not really going to mess with this. We're just going to monitor it and kind of go from there. Drug-wise, what are we doing? Well, we got to get those lower airways open. The fact about this is that they still have to have adequate inhalation volume. If they can't do it on their own, then we're going to have to assist it. Maybe it's with CPAP. Maybe it's an inline type of treatment with an endotracheal tube and nasally intubate them or something like that. Maybe they can do it on their own, but you have to assess that on a case-by-case basis with your patient. So albuterol, Atrovent, okay, if you're going to use Atrovent, usually going to do it the first time, do a little CombiVent thing, and try to dilate the airways, try to dry them up a little bit. Sometimes, again, nebulizers work well. Sometimes the face mask works well. Sometimes the CPAP is necessary. So whatever is necessary for that patient at that particular time, we're going to use that to their benefit. For the advanced providers, get the steroids on board if you've got them. It's going to help reduce that inflammation. Is it going to work on scene? No. Is it eventually going to kick in and probably help? Yes. Are we going to see the benefits of it? Probably not. But in the long run, it will kind of get that process started. And then lastly, for your really severely clamped down patients that aren't ventilating very well on either end of the spectrum, emphysema or bronchitis, maybe now, if we can't get an IV established, or if you're not able to, maybe you have protocol, or you can have someone that can intervene with some type of intramuscular agonist, like, again, epinephrine perhaps, or terbutaline, or something along those lines to help dilate those airways and get some better airflow into these patients. Right? Now, as I said, we're not going to fix the underlying problem. We're just going to help relieve the acute exacerbation that occurred in the produce aisle because they saw each other and got too excited. So we do that and do it pretty well. And so they're back to their baseline, which for us is not normal, but for them it is. And we take them to the local emergency department. They get there, they're stabilized, the steroids, fluids, albuterol is flowing like wine, and they're feeling much better. So they get admitted overnight just to be observed, and they happen to just get a room next to each other. And so they start talking, and they're thinking, you know what, we were stupid. Why didn't we just do what we were supposed to do when we were younger? We could have avoided all this heartache that we've had throughout the years. So they made a pact that if they both get out of the hospital, that they're just going to live their lives together, and that's going to be that. So fortunately enough, okay, they're both discharged on the same day. They go down to the chapel in the hospital. The minister happens to be there. They get hitched, and they walk away a married couple, and the story ends on a happy ending. So that being said, that is Earl, the emphysemic, and Betty, the bronchitis patient. And I'll take your questions. I don't know. I think you may be muted. Um, if you want to try to tap into the chat room, I can see that, and I can try to answer your questions. If you want this presentation, you are more than welcome to it as well. My email is at the bottom, as you can see there. You can email me there, and I can send you the presentation, and you can use this for whatever you would like. And again, if you have some needs for your own departments, I'd be more than glad to do it on another Zoom for y'all. So just let me know. But I'll stick around here for a few minutes. You know, we're just a little over the time, but again, I'm still watching the chat room here. So if you have a question, by all means, throw it on up there.
Thank you so much, Chris. And if anyone has a question, they can use the raise hand feature on their Zoom toolbar, and I will click the little button that will then allow them to unmute themselves, or they can enter it into the chat.
Who was it that just asked that? Reed. Unfortunately, neither one of them had children because they never got married individually. So I don't think they're probably going to produce now unless they decide to adopt. So I can't say that their kids would approve, but I'm sure that if they did, they probably would approve, yes. Yes, Nancy, you see a very similar presentation of COPDers like asthmatics. There's some literature that's out there that actually puts asthma under the COPD umbrella. And the only reason why a lot of places don't is because it is a chronic condition, but it's also a condition of happenstance. You know, every time that Betty and Earl wake up every day, they've got their condition and they've got a consequence of it that affects them on their daily living. Asthmatics, as you know, they need a trigger. And so when a trigger kicks in on that day, yes, they are now having a problem. So they have a chronic underlying problem. It just doesn't affect their everyday living overall. So that's why it kind of doesn't fit into the COPD definition sometimes. But a lot of the similar things, the inflammation, the airway trapping, the mucus production, the inflammation and the airway constriction, all those things you see in asthmatics as well. And the treatments are obviously similar.
Chris, thanks again for being here tonight. That was fantastic.
Oh, thank you very much.